Hello, fellow doctors and students. Welcome back to this PYT series, and this is episode 5. And this topic is very underrated but yet difficult to understand because many of the times we leave this topic before examination. So, in this video, I'm gonna discuss all the gaps, arterial blood gas analysis, and renal tubular acidosis. So, let's first see the serum anion gap. Yeah. So, first see the serum anion gap. It is serum sodium plus unmeasured cations equals to serum chloride minus serum chloride plus unmeasured anions and bicarbonates. So after rearranging this, we get the formula that is serum sodium minus serum chloride plus bicarbonate equals to unmeasured anions minus unmeasured cations. So most of the times, what we forget is that there is bicarbonate also. So you have to remember this that there is bicarbonate, but no potassium is there. Potassium is not there in this formula. So unmeasured anions minus unmeasured cations equals to 8 to 12 millicoulomb per liter, but we can take the average value that is 10 millicoulomb per liter is also right. So most of the times we forget this value and we forget that there is no potassium and we also forget that there is bicarbonate in the formula. So if you can see you can make by this formula that अगर unmeasured anions हमारे increase होंगे तो उसके साथ साथ anion gap भी हमारा बढ़ जाएगा so that we can see in diabetes mellitus, diabetic ketoacidosis, lactic acidosis and uremia. इन सभी में unmeasured anions increase होंगे इसमें unmeasured anions कौन सा हो यूरेट और यूरेट आयन in lactic acidosis there is lactic acid and ketoacidosis there are ketones. So there is one more concept which will be helpful in solving questions in medicine and pediatrics also. If there is loss in bicarbonate, let's suppose that we excrete the bicarbonate ions via urine, so that will be compensated by chloride, or if we lose bicarbonate from the intestine, so chloride will compensate it, and the anion gap will become normal. So it will be helpful in solving medicine and peds question. This is the basic concept and yet important concept also. So this is called नॉर्मल एनाइन गैप मेटाबॉलिक एसिडोसिस. इसमें क्या होगा कि अभी मैंने एक्सप्लेन किया आपको कि बाइकार्बोनेट जो है वो जो बाइकार्बोनेट एक्सक्रीट हुआ है वो क्लोराइड से कंपनसेट हो जाएगा सो दैट metabolic acidosis will be normal anion gap or anion gap will not be affected. So moving forward, so we can see as there is compensation by chloride, so it is called hyperchloremia because chlorine levels will increase in blood. So it is called hyperchloremia. So now there are three diagnoses or three sorry so there are three differential diagnoses. There is slip of tongue. So there are three differential diagnosis of normal anion gap metabolic acidosis. First is RTA type 1 and type 4. There will be type 4. RTA type 1, type 4 and type 2. VIPoma, which is a pancreatic tumor or it is a malignant tumor. And there is ureterosigmoidostomy, which we do in urinary bladder cancer treatment. Okay. So now we have to differentiate between VIPoma and RTA type 1, type 4 and type 2. So how we will differentiate? We will see urine anion gap. So first we have see the serum anion gap, then we are going to urine anion gap. So in this urine anion gap, we have to see that there is urine sodium, potassium minus urine chlorine equals to unmeasured anions minus unmeasured cations. So this is same. This is same as serum anion gap, but now you can see here that there is potassium which has been added on, but there is no bicarbonate. So these both are PYQs. You have to remember the formula and you have to remember which ions are there in which anion gaps. Okay. So now there is no numerical value in the urine anion gaps. There is only negative and positive like Weber's test, Renal's test we do in ENT. So if negative urine anion gap is there, that is normal, and if there is positive urine anion gap, then it is abnormal. So so we have to move forward by this. In RTA, if you see, there is In renal tubular acidosis, in renal tubular acidosis, what happens? Hydrogen ions are not secreted. So the hydrogen ions or the protons cannot combine with the ammonia in urine, and NH4 positive is not formed. So this reaction will not take place, and therefore the ammonium ion which was earlier formed in urine is now not forming. So it will decrease in urine, and there will be positive urine anion gap. As urine anion gap value increase, as we know the formula, urine unmeasured anions minus unmeasured cations. So unmeasured cations has decreased, so there is increase in urine ion gap value. So that is abnormal. So now concluding, first we have to see whether it is high anion gap metabolic acidosis or normal anion gap metabolic acidosis. If it is normal anion gap metabolic acidosis, then we have to see that there are two differentials, RTA and VIPoma. Uretrosigmoidostom is also there, that is in urinary bladder cancer treatment. Just give me 1 second. Yeah. So we have to see whether it is RT or VIPoma. To differentiate between RT and VIPoma, we have to see anion gap, urine anion gap basically. If the urine anion gap is normal or there is negative urine anion gap, then it is VIPoma. If positive urine anion gap, then it is RT or renal tubular acidosis. So this is so simple. I have simplified it. Now we are moving to arterial blood gas analysis. So this is very simple, but students or when I was a student also, I used to make the questions wrong in this. But now I have made very simple. I have made it very simple. First, remember the normal parameters of blood. That is pH is 7.35 to 7.45, which is average comes out to be 7.4. Serum bicarbonate levels which are 22 to 28, and the average is 24. Partial pressure of CO2 in arterial blood. It is not in alveoli. It is arterial blood. So it comes out to be 35 to 45. Average is 40. And anion gap which is 8 to 12 we have seen earlier also. So now you have to remember the all the parameters of the blood first, and there always comes a question in every exam. We have to check for compensation whether it is appropriate or not. So there is a Winter's formula for this. So there is a Winter's formula for this. You have to remember this formula that you have to multiply bicarbonate with 1.5 and then add 8 in it, and then do plus 2 and minus 2. If the partial pressure of CO2 comes between 30 to 34, then compensation is okay or fine. If it is not there, then it is no compensation or uncompensated. Okay, give me 1 second. Yeah. So now I'm gonna tell you the algorithm to solve this question, to solve the questions of arterial blood gas analysis. It is very simple. First, you have to see the pH of the blood. There will be a report given to you of ABG. First, you have to see the ABG. First, you have to see the pH in ABG, and then you have to see whether the pH is less than 7.35 or more than 7.45. If less than 7.35, then it is acidosis. If more than 7.45, then it is alkalosis. Very simple. If there is acidosis, you have to see the bicarbonates. Irrespective of whether acidosis is there or alkalosis, you have to see the bicarbonates. After seeing the bicarbonates, you have to see if it corresponds. Let's suppose bicarbonates normal value is 22 to 28. So for metabolic acidosis, it should be less than 22. For metabolic alkalosis, it should be less more than 28. And then if there is no correspondence, like suppose bicarbonate value is 29, and you are seeing that, and there is metabolic acidosis. Okay, then you will check the value of partial pressure of CO2. If the CO2 value corresponds to the value of acidosis, then it is respiratory acidosis. Example, normal is 35 to 45, and we know whenever there is increase in carbon dioxide in blood, increase CO2 in blood, leads to respiratory acidosis, or I can say respiratory acidosis because of increase in CO2 in blood. And I can also say that a decrease in CO2 or CO2 washout causes respiratory alkalosis. So I'm going to tell here a very important concept. First, you have to see this. Remember, whenever there is increase in CO2 in blood, it causes respiratory acidosis, which leads to fast breathing, which triggers fast breathing. Later on, give me 1 second. Later on, which leads to CO2 washout and causes respiratory alkalosis. Respiratory alkalosis. So I'm explaining this again. If if there is a ABG given to you, so first you have to see the pH, and then you have to see whether it is less than 7.35 or more than 7.45. If it is less than 7.35, then it is acidosis. Then you have to see the bicarbonate ions. Irrespective of acidosis or alkalosis, you have to see the bicarbonate ions. If the bicarbonate ion value corresponds to the acidosis or alkalosis, then it is simple, it is metabolic acidosis and metabolic alkalosis. If the value does not correspond to the pH value, then you have to see the partial pressure of CO2. If partial pressure of CO2 is less than 35, then it means it is respiratory acidosis. Sorry, if the partial pressure of CO2 is more than 45, if the partial pressure of CO2 is more than 45, then it is respiratory acidosis. If partial pressure of CO2 is less than 35, then it is respiratory alkalosis. And to see the compensation will be opposite of that of primary cause. Let's suppose, let me just give me 1 second. I'm gonna explain this to you. Yeah. So for this, I have to explain the, yeah. So now I am going to explain you the compensation. Okay. So let's suppose there is metabolic acidosis. Bicarbonate value is less than 22. Partial pressure of CO2 is, so now there is metabolic acidosis. Now there will be compensation. How there will be compensation? Compensation will be by respiratory alkalosis. Okay. So for respiratory alkalosis, what should be there? There should be CO2 washout to occur, to happen. For CO2 washout to happen, there should be acidosis, and in response to that, there would be compensation, and that will lead to CO2 washout. And if there is metabolic alkalosis, then bicarbonate is more than 28, and compensation by respiratory acidosis. Compensation by respiratory acidosis where CO2 will be more than 45. Now, if there is respiratory acidosis, then what will happen? CO2 is already more than 45, and now compensation will be by metabolic acidosis, metabolic alkalosis. That is, bicarbonate would be more than 28, and vice versa. Okay. So now you have understand this, and I will move to RTA, renal tubular acidosis. This is our last topic for today. And so in this topic, renal tubular acidosis, But points we already know that it is a normal anion gap metabolic acidosis, there is hyperchloremia, and urine anion gap which is positive in type 1 and type 4 also. So these are the basic and initial points we already know. Now we have to see the different types of renal tubular acidosis. So renal tubular acidosis, it is very simple. The basis, the basics are that the kidney is incapable of excreting out proton ions or protons. So the hydrogen or the H plus ions increase in blood, due to which there is acidosis. So H plus increases in blood, which leads to acidosis. This is common in all of them, which leads to nagma, and there is hyperchloremia, and there is urine iron gap is positive. So now we have to differentiate between all three or all four. So first will we see RTA type 1. There is hydrogen potassium ATPase exchanger pump at distal tubule. So there is distal acidification is not normal or distal acidification is absent. So there is this one concept. I am going to tell you this one concept. Even if the जब भी यूरिन जब पीसीटी से आता है वहां पर एसिडिफाई होता है उसके बाद डिस्टल ट्यूब्यूल में एसिडिफाई होता है. So the last part determines whether there will be acidification or not, or what will be the pH of urine. अगर डिस्टल एसिडिफिकेशन एबनॉर्मल है या फिर डिस्टल एसिडिफिकेशन एब्सेंट है तो जितना भी यूरिन किडनी से या पीसीटी से वॉश आउट होके आ रहा है डीसीटी डिस्टल ट्यूब्यूल के पास, अगर डिस्टल ट्यूब्यूल पे पंप काम नहीं करेगा प्रोटोन पंप, देन देयर विल बी नो एसिडिफिकेशन एंड the urine will be alkaline or pH will be higher. So in type 1 there is potassium and there is potassium and hydrogen ion ATPase pump which is defective, and there is no distal acidification. So the urine so the urine pH will be more than 5.5. Normal urine pH is less than 5.5 or less than 5. So here will be urine pH is more than 5.5, and it is most common inherited, and it is most severe and less than 30 years patient, and males are more than females. So you have to remember these all are PYQs. I have written all PYQs here. Now you have to see second, it is Fanconi syndrome. It is very simple. There is PCT defect there. So there is reabsorption defect. There will be sodium will not be reabsorbed, glucose will not be reabsorbed, phosphates will not be reabsorbed, and there will be calcium will also be not be reabsorbed, and vitamin D also. And now we will see type 4. So it is very simple. It is ENaC defect at collecting duct, or there is ENaC resistance, or there is aldosterone deficiency. Now type 3 is very simple. It is bicarbonate reabsorption defect. It is also called marble brain and bone disease. So there is cerebral calcification and osteopetrosis. Once I will complete this topic, I will take up metabolic bone diseases, osteopetrosis, and Paget's disease. So there I will also discuss these points. So now for now you have to remember that type 3 is bicarbonate reabsorption defect. It is also called marble brain and bone disease, and it occurs due to acetazolamide, which is carbonic anhydrase inhibitor. These all are PYQs. All are PYQs. I've written all PYQs here. Now for type 4, it is most common in adults. It is mildest. It is more in males than females. It occurs in patients with diabetes, and it occurs in adults, so more than 50 years of patient. So now I am moving forward with the iron values. So you have to see serum potassium. In type 1 it's low. Why it's low? Because hydrogen potassium pump was not functioning. So it is an exchanger. So what happens when there is exchanger? Hydrogen will come in and potassium will move out. So if there is no hydrogen moving out, so potassium will be increased. So potassium will, if there is, let me explain to you. Uh, so this is exchanger. Here what happens, that there is potassium coming in and hydrogen coming out. So if it does not occur, then it levels increase in blood. levels decrease in blood, it will not be reabsorbed. Potassium will not be reabsorbed. So the potassium will be low. And in this also potassium is low. Why? Because it is a reabsorption defect, complete reabsorption defect. And there is potassium high. Why there is potassium high? Because you can see, as it is a need, as ENaC channel is defective, or it has or there is resistance at ENaC level. So what will happen? There is loss of sodium, there is loss of water. To compensate this, the potassium, to compensate for the positive ions, there is increase in potassium in the blood, and it is associated with amiloride, which is ENaC inhibitor. It is also associated with CKD, ACE inhibitors, ARBs. They all block ENaC channels, and potassium sparing diuretics. They all block ENaC channels. So now coming back to this, the urine pH, I have told you, if if there is no if there is no hydrogen excreted in the urine, then it will increase in blood. So urine pH will be higher, which is near to the basic level of the urine. And in type 2, there is decrease in urine pH, or there is normal urine pH. Why? Because there is distal acidification is normal. Distal acidification is normal here. So there is urine pH is less than 5.5, and here it is variable. And bicarbonate excretion, to compensate in type 1, for compensate for acidosis, bicarbonate excretion decreases, but here it is maximum, because distal acidification distal acidification is normal. And here it is 5 to 10%. Urine ion gap, we know that it's positive in type 1, it's positive in type 4, but it is negative in type 2, which is normal. So this is also PYQ point. And now type 1 is associations of type 1, that is Sika syndrome. It is an autoimmune disorder. Short stature, medullary sponge kidney, nephrocalcinosis, that is renal stones. These all are PYQs. You have to remember these points. The type 1 is associated with autoimmune disorder, which is Sika syndrome. There is xerostomia and all other things. Short stature, medullary sponge kidney, nephrocalcinosis, that is renal stones. Type 2, it is called as Fanconi syndrome. And type 4 we have already seen. So now the treatment part is, as in all these there is acidosis, in all as there is acidosis, so bicarbonates we have to give in all. We have to give for treatment, as we have to give treatment in all as bicarbonates. In type 1 there will be magnesium supplementation and potassium supplementation. Because potassium was low, there was hypokalemia, as decreased potassium in blood, and citrate syrup for stones. And type 2 is with vitamin D responsive patient, and we have to give bicarbonates सब में देने हैं क्यों? Because there is acidosis. So to compensate for this, we have to give bicarbonates from outside. And also we have to give potassium, as there was hypokalemia. And thiazides, these are not loop diuretics. We have to give thiazides. And here it is potassium restriction. Why? Because ENaC was inhibited and increased potassium in blood was there. So we have to do potassium restriction. This is important. And we have to give fludrocortisone also. Why fludrocortisone we have to give? Because it is aldosterone agonist which act on ENaC channel. So now we have covered RTA, we have covered anion gaps and arterial blood gas analysis. Now tomorrow I'll cover osteopetrosis, Paget's disease, scurvy, and osteomalacia. Tomorrow I will cover these four topics. So yeah, take care, bye bye, and have a nice day.